Just to remind for those that excuse me, don't have, do not remember, let's say, what is the structure of our meeting. Usually we start with the core, which this is the bifurcation, and after that we have a topic in which we go in details. And today, this edition of the course, we are going to speak about coronary calcification, the role of coronary calcification, and how we can address this really serious problem in interventional cardiology. And I give you the floor to Professor Gill Robert, our friend, just to introduce this very, in my view, important topics. Thanks you.
Thank you very much, Valerie. Once more, thank you for inviting me. First, I would like to tell you that this is a small mistake. In my opinion, this is 12, not 11. I don't believe in this 10 and 3/4. For me, this is 12, a 12th edition. But you know, that was prepared very late at night, and just I add additional points. Anyway, once more, this is well-known sentence of my master, Patrick Serruys, that calcium has always been the worst enemy of interventionalists. Calcium impedes crossability, expansion, embedment, and coverage of the lesion. We know it since many years that calcium is not the friend. What we observe in our labs during our daily activity, that we are forced to treat people with more and more complex lesions, with a more and more percentage of calcific ones. And this dramatic increase of calcific lesions between the end of 20th centuries and beginning of 21st, it's well-known evidence. And of course, there are many proposals to explain why it happened, but let's go by the background of this. First of all, calcification is a normal process which exists in our bodies. It exists in vessels, in organs, and because of that, there are many works already was done, and it's still, let's say, occurring to establish the mechanism of these calcifications. And of course, these 5 of them already presented on this slide: losses of inhibitors, calcium and phosphorus homeostasis, osteochondrogenic differentiation of vascular cells, apoptosis, circulating nucleation complex paracrine factors, and matrix degradations. So everything and nothing. So very general just features. What we know that we are on the way to understand, because if we understand, we better and more effectively should treat our patients. And of course, we know that young artery is very elastic, pulsatile, but due to the molecular and cellular changes during the time life, comes to remodeling of the vessel, which is of course associated with cardiovascular diseases and of course cardiovascular events. And much more also generally we can say that we are genetically determined in terms of pro and contra calcifications. The biological aging is something normal, but we don't understand, or rather we don't want to understand that environment and modifiable factors due to our style of life, diet also cause the changes, not in a good direction for our arteries. This dysfunction, senescence, proliferation, migration, mineralization, matrix deposition really affect the intima media thickening, matrix remodeling and calcification, finally arterial stiffening and consequences, the cardiovascular events. I would like to say that we know already at least 4 very strong factors which are responsible for calcifications, not only in vascular system but also in heart. This is a level of calcium ions. This is phosphates, the inflammation, and age. Telling today about coronary vessels, we should concentrate and focus on arteries. And of course, calcifications means increased stiffness, the hypertension, and the changes in flow due to the stenosis or even occlusion occurrence. And of course, we have 2 forms of calcifications. One so-called intimal, the second medial. Today we should concentrate on intimal, which is associated with inflammation process. It is very tightly attached to atherosclerosis in chronic coronary syndromes and also in acute coronary syndromes. It's a matter of clinical presentation because of the speed of calcifications, of course determined by our genetics. And we would say that vascular means focal, but of course diffuse forms of calcifications also exist. But we have to remember that this plaque formation with calcifications means myocardial infarction, stroke, limb events, depending on the let's say vascular territory which we are thinking of. And by years we believed that calcifications of the lesion works as a kind of protection. This is the only part of the truth. This is not a time to discuss on that, but maybe during the discussion. But I would like to bring your attention to the nodules, calcific nodules forms of calcification, which prones acute coronary syndromes. Phosphates, already mentioned on one of the slides, is very important in the process of calcifications, and the so-called balance of phosphates is very complex process involving bone and intestinal absorption, dietary phosphate, and renal exertion of phosphate. So it means that there is a balance between the income and outcome of the phosphates. Everything depends, of course, on these additional features, changing a little bit this flux of the phosphates. What we also know that inflammation distracts endothelial function. Also by the decreasing of nitric oxide, which impacts the activity and work of vascular smooth muscle cells and vascular intensive cells, and so-called osteogenic transdifferentiation process, which transforms these cells into osteoblasts and intensifying the calcification. This is also the part of the process. What is very important that all of the connective tissue it's affected by calcifications. And of course, once more, hyperphosphatemia, which is caused by diet of nowadays. If you look at the content of our diet, is much higher than it was in the past. So this is one of the reasons that we see acceleration of the calcification process in our patients. Once more, it impacts osteochondrogenic transdeformation. We also knew the enzymes, the line of the processes which exist and are connected to calcifications. And of course, in a case of decrease of calcification inhibitors, we know these enzymes increase the cytokines and chemokines, increase the matrix metalloproteases and calcifying extracellular vesicles. So this is well-known processes in animals and also confirmed in human bodies. So we should know these processes because based on that we can construct new drugs stopping the process of calcifications. We also knew that the type of macrophages, let's say, is an important issue in terms of calcifications. However, we are unable to steer this process so far. The process of calcifications means hydrolysis of ATP, then hydrolysis of phosphates into the pyrophosphates, and formation of as you see, sorry, as you, no, it's not this direction. Oh, sorry. This formation of hydroxyapatite, this is the reason of vascular calcification. So just to summarize this part of the lecture, we very well know the risk factors for coronary vessel calcification. So advanced age, diabetes mellitus, dyslipidemia, hypertension, male sex, cigarette smoking, renal disorders due to the hypercalcemia, hyperphosphatemia, parathormone abnormalities, and dialysis. So if you look at the spectrum of our patients, so almost at half of them are really affected by this situation, even 70%. So in 2011, 2012, we had 35% of calcifications in our patients. Right now, we have much more than 50%. And of course, during this time of searching for reasons of calcifications, we found that the statins administration is also affected by increase of calcifications. There is also some interactions with vitamin K dependent proteins. So we found these relations. It was found. This relation was found. And of course, so-called pro-calcific effects of statins may be mediated through prevention of vitamin K dependent inhibition of vascular calcifications. However, for our luck, because statins are a basic treatment for or against cardiovascular problems, we found that the calcifications is increased, but it doesn't translate into cardiovascular problems. This is for sure. Taking into account meta-analysis, we have to say that statins do not reduce or enhance calcifications as measured by Agatston scores in asymptomatic populations and high risk of cardiovascular diseases, but seems to slow down their calcifications, coronary artery calcification progress. So this is very important moment because we know that can be associated, but it doesn't translate into the clinical consequences. But of course, we know that calcifications are the markers of worse outcome in acute coronary syndrome patients. Here you can see the well-known trials, Horizon, AMI, and Acuity, and this is a well-known thing that the higher, the more calcified lesions, the more percentage of major adverse cardiovascular events. One of the explanation of that is limitation of stent expansion in coronary calcifications, and we know that the univariate, multivariate predictors of stent expansions. So we know it quite well, and of course, calcified plaque adversely impacts stent implantation. It remains a challenge for the interventional cardiologist. This is for sure. And how can we translate this knowledge about impact of lesion calcifications? That because calcifications means let's say worse outcome of the patients, and also we have to be aware that even we can injure the surface of the stent, decreasing the efficacy of the drug-eluting stents, and increase the percentage of myocardial infarction in the patient in such situation. Is not a good issue. Anyway, we can use so-called coronary artery calcifications caused by tomography, by computed tomography. This is very important message, and based on that, we can calculate the outcome of the patients, and the lower calcific or Agatston score, the better outcome of the patients. And we found also the so-called cutoff criteria for this parameter. This is equal or more 300 units, and we can use this information as a help or useful tool to assess the prediction of our patients. And we know that the bigger this calcific coronary artery calcific score, the worse situation of the patients, the bigger annual cardiovascular event rate. And we can also use this score to start the real prevention in our patients, also with the statin usage. Trying to understand and to believe that these statins, even with small increase of calcification, doesn't or don't affect negatively our patients. That's just in conclusion. Today, it is clear that cardiovascular calcifications are multi-phase disorders occurring in different milieu, due to the different pathologies. Hyperphosphatemia is a determinant of vascular calcification in chronic kidney disease, while inflammation causes calcification associated with atherosclerosis. These findings marked how different pathological phenotypes exist, not only between vascular and valvular calcifications, but even within the same vessels. And at the end, I would like to say that it's very good that a lot of experiences, trials are already done, and the work is going on. Helpfully, let's say, hopefully, we will get not only drugs to slow down the process, but also we can use very new dedicated devices to fight with the calcifications. Thank you very much for your attention.
Thank you, Robert. It was really a very interesting presentation. Probably we missed the time just to get in details. Any questions, comments?
Well, perhaps just a quick one. There are two important points and take-home messages from the presentation of Robert. I don't know if you can hear me. It's on. Very quick one. Let's see if it works now. If not, let's
You can
see.
take the microphone.
Yeah, do you hear me now, perhaps? Well, just the 2 points I marked down, which are the first one. Calcification is just the tip of an iceberg. Finding calcium on one coronary spot means most likely we are going to find calcified lesions in the other segments of the coronary tree. And that's why it is key, and I tell it especially to the younger colleagues in the room, always take experience of a previous attempt in another coronary segment. If it was difficult to treat the coronary vessel and the coronary segment in that coronary artery, most likely it's going to be difficult in the remaining coronary arteries. That's number one. And number two, to add complexity on complexity, Robert said it very nicely, that calcification is a systemic problem. So it doesn't exist a calcified coronary tree, it exists a calcified patient. And calcification starts from the puncture site all the way up to the coronary artery. And this, of course, makes this procedure particularly challenging and difficult. And last but not least, these are patients with often associated comorbidities, which make them at higher risk of having complication, simply because they are intrinsically at higher risk, those patients. So this means that we need particular care in managing this patient.
That means probably that we should find a way to identify this patient in advance, because these patients very often go, as you said, with comorbidities, and one of them is kidney disease and renal insufficiency. And probably, in my view, we should find a course or something just to find and identify this patient in advance and be prepared for them. Because when you lay the patient on the table and you start the procedure, you cannot draw back, and if you are not prepared, this is not a good option. Any other comments?
Probably we should, maybe we should switch to some, let's say, primary prevention programs for the patients, which are selected based on the ultrasound examination of the femoral artery and carotid artery, not because of the intima media thickness, but because of the presence of the calcium, because it is very easy to find for any, even for any cardiologist with the short training of a few hours, it will be very easy to find. And as Professor Barbato said, the calcium is not only in the coronary cities everywhere. I don't know what is your personal impression, but almost in 100% in my patients with the calcification in coronaries, they have calcification also on femorals and even on the radial. And ultrasound is very easy to do and non-invasive.
Thanks for the comment. And now it is my pleasure to invite Aki Kumaira. We all know her, and it is really a great privilege for us to have her around once again. I think very important to, when we start treating calcium, is to have an idea what is the distribution and what are the markers that we can facilitate and help out build a strategy how to address this calcium. And of course, this can be done with intravascular imaging. And we're starting with the lecture for Kiko, how we should decide, how we should choose these two modalities that we have and when. Thanks, Kiko, once again for coming.
Okay, so nice to see you, everybody. So I have two topics, but I changed the topics order because I think this is more important first, and then I talk the next one. So the first I'd like to say how to decide the calcium evaluation using the IBAS or OCT. So let's start with this basic. We analyze about 500 patients by OCT and IBAS in the same patient, in the same region. And also we compare with the coronary angio. And point number one, don't forget to look into the coronary angio carefully. This is actually very important. So this graph shows the comparison between how it looks like IBAS or OCT calcium compared to the angio. So the x-axis is maximum arc of the calcium by IBAS and OCT. And y-axis is angiographic appearance. So in general, if you see the big calcium by IBAS or OCT, you see the high prevalence of the calcium detection by angio. That's number one. However, if you look into the high calcium arc, some of the calcium, which we could see very big chunk of the calcium by IBAS or OCT, sometimes we couldn't see the angio. And actually, I recognized these things almost 20 years ago. But I thought at that time, this is due to the poor resolution of the angio. But after long years, when I look into this data by myself, I saw that's not correct. And so this is an example. So you see the very simple distal right coronary artery mild region. Angiographically, we don't see any calcium, right? And then we did the IBAS, and then we recognize actually it's a big calcium. If I analyze the maximal arc, it's more than 270. It's a big calcium. Okay, we look into the OCT in the same patient. And what we found is actually this calcium there is big calcium arc. It's similar to the IBAS, but those calcium is quite thin. So that's how it looks like, meaning if you look into the angio, and then if you don't see the calcium, most likely that's a thin calcium. And we are really looking for the total amount of the calcium volume by angio. And IBAS cannot tell because we couldn't see the thickness of the calcium. But if you look into the OCT, you recognize this type of the calcium is actually quite thin. To answer that question, we did this small comparison. First, I picking up the calcium by IBAS, or more than 180, which is actually big calcium. And then in the same patient, we compare the OCT, the stratification, angiographic visible calcium versus non-visible calcium. And then what we found is angiographic non-visible calcium is actually quite thin calcium. And then they have the good stent expansion, no matter how we use the procedure. So first step is if you start seeing the angio, and if you see the chunk of the calcium angio, that's indicating the allotable amount of the calcium volume. And if you look into those, probably OCT can better because you can see the thickness of the calcium. And sometimes IBAS is confusing because we couldn't see the calcium thickness. And as I show in this case, there is a large amount of the calcium, but because we couldn't see the thickness, we feel that's a big calcium. And you can differentiate based on the visibility of the angio. then we developed the calcium score because we thought this to be more accurate. And then we picking up the two separate cohorts. One is from Japan and one is from United States. And then we developed the calcium score in the first cohort. And then we analyzed everything because we could analyze in the calcium is the thickness, arc, or length, many different ways. And then ultimately, using the final stent expansion as outcome, we ask ourselves, what type of the calcium picture is important to predict stent expansion? And this data is very unique or interesting. I thought so at the beginning, because those are the different type of the future of the calcium, but talking the almost same thing, meaning the angle is important, and thickness is important, and also the length is important, meaning overall calcium volume is important to predict the calcium stent expansion. And based on the regression coefficient, we developed the calcium score. If the angle is large, say 2, and if the thickness is thick, say 1, and long length, say 1. And in total, we developed 0 to 4, and then you can see if the score is high, you see the stent expansion is poor. And by the way, that's one story. But at the same time, what is really the mechanism of the stent expansion in the severe calcified region? We really need a calcium fracture. What this meaning? When you look into this left-hand side, that's the circumferential calcium. And the right-hand side, the white arrow, you see the calcium was separate. This meaning calcium fracture, meaning the stretching of the calcium, and then finally they are separate. Without having the calcium fracture, we cannot make the good stent expansion in the severe calcified region. And then we ask ourselves, what is the important parameter to predict a good calcium fracture? And there is a multiple things, but at the end we found minimum thickness of the calcium is the most important. In the bottom right side, you see a lot of dot, and the dot in pink indicating the region which got calcium fracture. And what is the most important is the sinus thickness of the calcium. And except one, all calcium which got fracture, by the way, this is all just balloon understand, no atherectomy or any additional treatment, just regular PCI. Using those, what we see the calcium fracture is the minimum thickness is less than 0.5 millimeter. And if the sinus thickness is thicker, we couldn't see the calcium fracture, so we need more. So that's one learning point. And then next, we start doing the calcium score by IBAS, because we use IBAS a lot, actually more than OCT. So we have to translate the learning from the OCT to the IBAS. And then, as I show in the first topics, is we have to understand angio help you. So the first, we start looking at the angio. And then if you don't see any calcium by angio, indicating the thin calcium, and we saw that's okay. Because IBAS cannot see the thickness, so we have to help something to determine the calcium thickness before starting the calcium score. So first, look into the angio. If there is a calcium, we start thinking the calcium score by IBAS. Next, first paper which we published by OCT, I saw that's too mild. So I changed my mind a lot after publishing the OCT paper. So because that's too mild, we have to look for more severe calcium if we really looking for the atherectomy, etc. So we developed based on the more than 270 as a minimum calcium to consider. So in this calcium score by IBAS, we start looking more than 270 as a maximum first. And then, if yes, we develop the calcium score. So what's the components? Number one, length. The calcium angle is more than 270, and long calcium is bad. It's just combination of the long and large calcium. The next is circumferential calcium. And circumferential calcium is very different compared to, let's say, 330 degrees of the calcium. Why? Because whenever you have non-calcium circumference, you have the good chance of the big dissection without calcium fracture. So they are very different. But if you have the circumferential calcium without fracture, you never ever get good stent expansion. The detecting the circumferential calcium is very important. Number three, I talk more in detail later, calcium nodule. Because calcium nodule is really the marker of the chunk of the calcium behind, and it's bad outcome. So you have to recognize that's important. And number 4, this is a lot of argument by the reviewer. The reason why we including the vessel size is IVUS can tell the vessel size, OCT cannot most of the time. And why? Because when you treat the lesion, and if you start with a small vessel or negative remodeling artery, if you don't treat well in terms of the calcium modification, you have much more chance having done the expansion. So actually, this is additional factor. But point was, if you start with the small artery, you have to have the less threshold treating more aggressive way, because that's more likely going with the poor stent expansion. So those are the 4 which we develop. And using the test cohort, we developed the calcium score, and we validate in the validation cohort. And you see the high score is poor stent expansion. That's number 1. And also, we had the patient already treated atherectomy. In the atherectomy cohort, even the high score, you see the good stent expansion. So atherectomy do well, even the high score. And finally, at the same time, more than 270 of the calcium by IVUS, but we including non-angiographic visible calcium patient as well in the most right-hand side. And you see none of them having the calcium score is 4, number 1. And also, even the high score, they are good stent expansion. So as I said, the angiographic non-visible calcium is typically they are thin calcium. So even looks much calcium by IVUS, they are good. So actually, even calcium score is high, they are okay. So those how we confirm works in terms of the calcium score by IVUS. And clearly, there is a very clear interaction between the calcium score and stent expansion in relation to the atherectomy usage. When we calculate the cutoff is more than 2, score 2, if score is more than 2, you have better benefit doing the atherectomy or more additional treatment. But actually, it's not just 2 or 3. High score, more likely you have benefit using the atherectomy, but low score is not. And actually, after developing this score at Columbia, we are different phenomena, meaning I teach everybody, so this is score this, so how to do it. And we talk a lot in terms of the procedure. And then finally, what we found after 2, 3 months or half year later, actually many times we downgrade the strategy because we recognize by IVUS, actually this is very focal circumferential. Let's try the balloon first, and if not, let's try something else. And then we found many of the focal calcium is actually doing well. So by doing so, we are detecting the most significant patient to be treated more advanced way. And importance is detecting the calcium fracture before stenting, because even though we treat even atherectomy, if you didn't do well, actually didn't help. So detecting the calcium fracture before stenting is quite important, but IVUS is sometimes difficult. How to detect is you look for the outside, because if you have the thick calcium, you really couldn't see behind because everything is acoustic shadow. But if you make the good calcium fracture, you have no calcium at the segment and you start seeing the behind. Detecting the outside is really indication of that you make the fracture. So after detecting the fracture, after stenting, you're stretching the artery and making the good stent expansion. And let's talk the case. So what do you think? This is case number 1. And this patient already confirmed the right coronary territory having the ischemia. It's mild disease, but we saw that has to be treated. And you see the mid segment is some disease. And just be careful, I couldn't show this. This doesn't work. So here. So here, there is some mild disease, and then we look into the IVUS as well. But be careful how it looks by angio. Looks like some calcium by angio, but not too much, but somewhere here. That's one thing, right? Okay, so this is the IVUS. And lesion, culprit lesion indicating D is actually attenuated plaque. It's actually soft. And proximal distal is big artery is quite normal. And number B, which I indicating by angio, is circumferential calcium. But when I measure this case, is actually this calcium is superfocal. It's almost like 1 or 2 millimeter. So I thought this is okay by balloon because that's good to be fracture. And it was. And by the way, this is calcium score is number 1. And then this is how it looks like the before and after. We're just using the balloon and the stent. And you see that the site of the circumferential segment, you see the nice calcium fracture here. Now you start seeing the behind. and this calcium is separate and making the good stent expansion. So this is really help us. Calcium score 1, only circumferential but super short, so it's okay by balloon only, and we predict, and actually it was. And this is final picture. So the case number 2 is completely different. Okay. Okay. Oh, okay, sorry. Okay, yeah. The case number 2 is, you see, looks bad. And first patient is post-bypass. And already it looks like the right coronary artery having some stent. And even you don't understand it's a stent or calcium, it looks bad. And as expected, none of the device was go. So the first operator did the rotor. And after the rotor, and he did non-compliant balloon using 3.5 and 20 atmosphere, and you see the right-hand side, it's really not expanded. So we feel this is really tough case. And fortunately, we could do the IVUS, and this is how it looks like, wow. So actually, this is, I remember this is almost 30, 40 millimeter, almost entire region was circumferential calcium. This is probably the worst calcium which I have never ever seen in the past. So it's really bad calcium. And fortunately, rotablator did work a little bit, and you see some sort of the small fracture here, and also nice loop ablation indicating rotablator effect, but other segment is circumferential. And already we're using the 3.5 non-compliant 20 atmosphere, so we know the balloon didn't work. So we have to work more. And we need more rotablator, and we are very confident. By the way, this is only calcium score 2, but really bad calcium, right? So, okay, so we did the rotablator using the 2 bar, and afterwards, the 3.5 non-compliant balloon up to 20 atmosphere, and looks like, you see the balloon open. Okay, we are much more comfortable. So look into the IVUS, and this is how it looks like before and after. At the site of the very circumferential calcium, and by the way, this type of the vibration indicating the polished surface by rotor. You can recognize how rotor effect at the site of the IVUS catheter, because typically rotor work at the wire bias by looking for the vibration. That's really vibration indicating the rotor worked. And at the site of the rotor effect, you see the nice calcium fracture here, and nice calcium fracture here, and here too. And it looks like very different picture, it works. But we worry a little bit, because we would like to put the stent from here to here, because this is the lumen area is still 4.5 square millimeter. And we did a lot of balloon, but didn't work. So looks like no fracture. And if we put the stent, actually, original most important segment was okay, but adjacent segment didn't okay. So if we put the stent, this is going to be underexpanded. So actually, this is important. Whenever we're treating the severe calcium, we just focus on severe calcium only. But typically, the calcium is very diffuse. When you put the long stent, adjacent segment may causing the stent underexpansion. So when you treat, you have to look for the entire segment. In this case, because we thought that the region was okay, but adjacent segment was not okay, so we decided to put additional rotor to make the fracture in this portion. Because this is already large segment, so we start using the 2.25. And this is after the larger bar and stent, and you see the fracture everywhere, and we are so comfortable, this is really good. And this is how it looks like the final picture. And we are almost, this is almost like, I think more than 2 hours, and we spend a lot of things in the cath lab, and finally, it's really good. And it's really different compared to the first and second one, and by looking more detail, how bad, and in terms of the arc, in terms of the length, and the effect of the device, and expectation of the entire segment of the region, and this is important to do the PCI for this type of the cases. By the way, I just make the one comment in terms of the uncrossable region. This is really the case, which had one case which I just showed, that's uncrossable region. And I do think most of the people, if you face the uncrossable region, everybody think that's severe calcium. I was wondering that's true or not for a long time. And then I had the opportunity having the fellow to answer that question. And I asked one fellow to bring in all atherectomy cases at Columbia with IVUS. And that's including 300 patients. And then I asked her to check all case report and also the angio, whether this is uncrossable or not. And then she found many of them was just because of the uncrossable, and some of them was actually crossable because, however, because of the severe calcium, we performed the atherectomy. And then we checked the IVUS. And then what we found is 60% is super severe calcium and tortuosity. And 24% is only severe calcium. And importantly, about 50% having no severe calcium, meaning less than 270 degrees. So what's happening is this type of the cases. You see the severe region here, and then you see the very angulated segment before. And at the site of the angulated segment, this is a place where the device didn't go. We look into the IVUS after the atherectomy. You see the nice reverberation, meaning the polishing. After atherectomy, device go. So what is the material which causing the inhibit crossing? And actually this protruding calcium. And amount of the calcium is actually not too much. And this type of the supplies actually happen about 15%. So I think still we need atherectomy to be able to cross, because still this protruding calcium inhibiting the device crossing. But more importantly, this case having the big angulation, that's causing the uncrossable region. And after cross, you should see how it looks like. And 50% of the time, maybe you supplies. Actually, the underlying plaque is not severe calcium. And then you take the release, and then you do the correction. You really don't need atherectomy anymore. Okay, the last case is, this is my colleague, Dr. Schlofmitz. We work together for a long time now. So this is really one important case which I would like to share. And this patient having the symptom for a long time, and then this is how it looks like the first time. So you see the angio, and please be carefully looking to this angio. And the lesion was proximal LAD, and I'm going to show longitudinal and cross-sectional, how it looks like the angio. And if you look into very carefully, the left-hand side telling the calcium is both sides. So it looks like very long calcium in both sides. And right picture telling you the calcium is actually circumferential. So even though angiographically, if you look into very carefully, you really understand this calcium is circumferential and very long and thick. And first time as actually treated outside of the other hospital. So meaning like somebody treated without any imaging. So they treated the balloon stent and relatively small and small stent. And then finally, okay, but not fantastic. The finally diameter stenosis is about 30%. And patient was okay, but coming back. And you see the proximal LAD, still some disease. And this time, we performed the OCT, and this is from the distal portion. And this is more than 1 year later. You see the stent was well healed, and looks like big, good artery, and well expanded, and neointima is very healed, and now we are reaching to the place. So this is the place what we see the lesion, and what you see. And stent was very underexpanded, and outside is almost circumferential calcium. And that's the reason why, from the beginning, the stent was not expanded. So to summarize, at the lesion, it's really napkin ring calcium, and circumferential calcium, and also the thick calcium. And the stent was super underexpanded, and small amount of the neointima causing this type of the issue. So this is really, like from the beginning, it was bad, right? And this time, actually this time was also not well prepared. And then even though people understand that's calcium, they try, but actually it's not doing well. And ultimately, at the end, it's 40% diameter stenosis. And based on that findings, and they prepared well, so we have to need something more because we know that's a calcium behind. And this time, they performed a laser with contrast. And then finally, looks like balloon expand. And finally, it was well. And you see how it looks like. This is OCT after the laser with contrast. and going from the distal, and the stent was expanded, and coming to the region, you see the calcium, but now there is a calcium fracture behind the stent and making the good stent expansion. So this is a summary. Even the calcium behind the stent and making the good calcium fracture, and after behind stent, you can see the good stent expansion. Okay, and because of this study, we checked the all data which we had, and we compared the laser with contrast just balloon, and we see many times we can see the calcium fracture, and even the old stent with poor stent expansion due to the severe calcium behind, we see the good treatment. And finally, we just published this data in the Circle Intervention last year, and this is how it looks like the neoatherocalcium in the old stent. And we recognize neoatherocalcium is, some of them is very inside, but sometimes it's surrounding the stent. And actually, this is not rare. Up to 7 years inside of the stent, the severe neoatherocalcium is about 20%. And the case, so then how we should predict the calcium treatment is actually similar to the de novo lesion. It's really important thickness of the calcium and arc of the calcium, and if both worse, and they are poor stent expansion. And if we finishing the poor stent expansion in the treatment of the in-stent restenosis with calcium, and of course they are poor outcome compared to without. So to summarize, the first talk is I do suggest go back to the basic, meaning angiographic visibility of the calcium is important, and that depends on the total volume of the calcium. And total volume of the calcium, such as arc thickness length, predict the calcium fracture and stent expansion. And OCT can see the thickness of the calcium, but IVUS cannot. And finally, the neoatherocalcium is about 20% in the old in-stent restenosis, and OCT evaluation, like the last case, is important to do the best choice of the treatment. Thank you.
Thank you, Akiko.
We are all feeling the students after this lecture. We are all feeling like a students after your lecture. This is not bad. This is very good, I mean.
So, any other comments? Questions?
I have a question for Akiko. There is one element you didn't touch upon, and I can suspect why, but I wanted to pick your experience and brain on that. Calcium depth. Does it depth? Yeah. Does it make any difference? Does it have an depth? How deep the calcium is in the coronary artery? Because we discussed about circumferential calcium, thickness, length. How about deep location, superficial location?
Yeah, I think the deep calcium doesn't affect anything for the stent expansion. And especially for the hemodialysis patient, deep calcium develop everywhere. Because there are different pathophysiology to develop the calcium. The hemodialysis patient is the more Menkes-Borg, such as medial calcification, so we see the deep calcium everywhere. So deep calcium doesn't affect of the stent expansion, number one. And second, it's very unlikely can see the deep calcium in the severe calcium case patient, except hemodialysis patient, because most of the calcium develop on the necrotic core, and starting at the deep side and superficial side, and then inside everything go to the thick calcium. So whenever you're having the calcium already, you have the superficial calcium together. So isolated deep calcium is not so often, and many times it was already attenuated by, we couldn't see because of the lipid on the top. So to me, when we look into as the, to predict the good stent expansion during the procedure, I really don't care the deep calcium. But one thing which is important is angiographically you see the calcium everywhere, like again, like hemodialysis patient. And you feel I have to work hard. But when you look into the IVUS OCT, you see that everything is deep side. And then actually you can downgrade the treatment because this calcium doesn't affect.
So intimal means attached and associated with atherosclerosis. That has to be the connection between the lumen and the vessel wall. This medial, as for dialysis, this is a systematic calcifications, and when since there is no connection with the lumen, so we are on a safer zone, and there is no necessity in majority cases to use additional devices to stent implanting the stent.
Yeah. Valerie. Yeah. Okay. Just one point. Actually, the circumferential calcium impedes our feeling of the size of the vessel. That's very important. Usually, those are parts of the vessel with a negative remodeling. But it could be not. That's why very important to crack first the calcium and then to take a look at the whole vessel to understand what the size of the stent will be afterwards.
Yep.
That's my point. It's just a comment.
Yeah.
So let's go move.
So,
Next.
next,
Okay.
please.
Can we go next? Okay. So next one. Recently, I'm very interested in the calcifying nodule because we are facing more cases, calcifying nodule. So I focus something new data explaining the calcifying nodule as well. But in general, more advanced way to look into the calcium. So let's go. Okay. So first, I go to some cases, but as I show the calcium score, but I show this, but has to be practical. Like what we discussed, negative remodeling, something like not align this score. So I would show some important case. So this is a patient, is 76-year-old male and severe AS, and you see that some very focal lesion in the proximal LAD. But we know this patient is severe AS and old, and that should be very calcified, and angiographically not super severe, but some calcium. And we worry, maybe we have to do something more. And then we did the IVUS. And actually, I'm surprised. It's much less than I thought. But what is important in this case, super important, is super negative remodeling. This is a proximal, B, and this is distal, and D. And look into the lesion, it's smaller than distal. Considering the vessel taper, proximal should be larger than distal, but C or D at the site of the lesion is smaller compared to D, meaning distal. So this is super negative remodeling. And you see the very eccentric calcium. By score, this is actually score 0, because none of the place is more than 270. This is not a nodule. So I thought this is something exceptional. We have to think about something which we couldn't explain well in the score. And then this is actually my personal feeling. I think this is something important, and I talk with the operator, and then actually we decide to do the obituary. Because if we don't treat well this eccentric negative remodeling calcium, maybe we stretch too much for the non-calcium site, and then may causing the perforation or supant expansion. That's something exceptional which we thought we need to treat more beyond the calcium score. And what we did is obituary, and you see the surface of the eccentric calcium was actually, you see, this is a very typical picture. At the site of the wire bias, that's a place where the rotablator obituary work, and you see original picture, no loop ablation, but after the obituary, you see the nice loop ablation. That's meaning the obituary polishing the surface, and then more reflection, and causing the loop ablation. And looks like very good obituary effect. By the way, before starting, I'm very confident this case should be the good obituary case because wire bias is hitting to the surface of the calcium, so most likely we can get a good polishment. If the wire bias the other way, we may not do, but because of this picture we did, and as expected, we see the good polishment. And more interestingly, after stenting, what we see is actually the calcium fracture here. You see the calcium here, and you see the calcium here. In between, there is no calcium. So really, this is my surprise. I thought the calcium fracture should occur in the large calcium, but this is really small calcium, which I see the calcium fracture. And this is really, to me, the surprise. But because of this portion, which very negatively modeling, is very good expansion. And this is how it looks like a summary. Now you see the proximal at the site of the MSA or region, and this time you see almost everywhere is similar size, and we are so comfortable this is a good stent expansion. And I do expect if we don't do the orbitally with just balloon stent, maybe we rounded up this very small stent expansion. That's what I thought. So this is just remember some exception which we couldn't tell in the calcium score. And this is the final picture. Okay, so now we are talking more detail how device can help and how device can help in relation to the imaging. So this is the rotablator, and after the rotablator, how we should see the effect of the rotablator by OCT. So you see this portion is very nice, round shape, polished surface. And always effect occur at the site of the wire bias. So if you look into how my orbitally work, checking the OCT segment, and then look for this type of the very round shape polished surface. That's the rotablator effect. And then if you compare the Pure, you see the more irregular surface, and then shape is quite different. If you look into this and this, you understand how effect of the rotablator. And this is after the stent, you see the nice calcium fracture. Typically, after the rotablator, calcium fracture occur at the site of the rotablator effect because polishing the surface, that's more likely seen. And also the calcium is hardness, is surface. And then even just modifying the surface, we see the calcium fracture. And orbitally is actually quite similar. And this is a case of the orbitally, this is a Pure, and this is post-orbitally. You see, again, nice polished round shape at the site of the OCT, meaning the wire bias segment. And after stent and balloon, you see the nice calcium fracture at the site of the orbitally effect. On the other hand, this case, the OCT catheter is hitting to the normal side. We expect that's not causing the effect because that's no calcium. And on the other hand, you see the thin calcium on the other hand. After stent, we see the calcium fracture at non-orbitally effect site because this is just thin calcium. And I asked my fellow to check where the calcium fracture occur in the orbitally case in relation to the orbitally effect. And bottom one is no modification, and the top one is modification. And this is a number of the calcium fracture, and you see the distribution is even thick calcium, as long as you have the orbitally effect, you can see the calcium fracture. So really the impact or effect of the orbitally or rotablator is polishing the surface. And because of the surface is the hardest of the calcium, and then you have more chance of the fracture, or you are just simply thinning the calcium and then making the fracture. So by comparing the orbitally case and different location of the calcium, at the site of the orbitally effect, we see the more calcium fracture, even the thick calcium. That's the bottom line. And this is a comparison between the orbitally rota, what's the difference. And then again, I asked my fellow to check everywhere in terms of the calcium modification. Number one, both orbitally and rotablator effect is 99% at the site of the wire bias. Most of the effect occur at the wire bias. It's very rare to see the effect non-wire bias site. Number two is rota work, small area, but orbitally can work even the large area, meaning like the as long as the wire bias is good location, orbitally may work better in the large lumen area. Number three is looks like differential cutting is better by rotor compared to the orbitally, because even small number of the cohort, we see some injury of the normal site in orbitally, but very rare in the rotablator. But in general, the effect is quite similar. That's our conclusion. Additionally, this is the data after the rotor how cutting help. And the top one is the rotor and cutting, and the bottom one is rotor and regular balloon and stent. And seems to be cutting balloon, some modification additionally on top of the rotor, because when we see the cutting balloon after the rotor, we see more calcium fracture compared just regular balloon. But this is a retrospective study. This is our feeling. So this has to be confirmed in the prospective manner. But I think there is some effect. And this is how it looks like. Again, we count in the fracture, and it looks like if we have the cutting balloon on top of the rotor, we see more fracture and thick calcium as well. And this is the lithotripsy, and you can see the pre and post and the final. And the findings of the lithotripsy by OCT is quite different compared to the rotor or orbitally. And everywhere we see the calcium fracture. And no matter how big the calcium, and no matter what of the wire bias. So that's quite different effect compared to other modality. So I would like to show this case. So this you can see old stent and very stenotic. And also, if you look into very carefully, and the mid-stenosis segment is even angiographically looks like the stent was underexpanded. And we did the OCT, and we found similar type of the cases, like by Dr. Shlomitz. You see the circumferential calcium behind, and the stent was super underexpanded and neointimal aplasia. And we did the lithotripsy of this case, and you can see the nice calcium fracture behind the stent and making the good stent expansion. So seems to be, like I show, in terms of the underexpanded case and treating the laser and contrast, and then looks like we could do similar effect, even the lithotripsy, even though now this is still off-label, but it seems to be real. And this is the final picture, and you see the nice stent expansion. Okay, finally, I'd like to share our recent bunch of the study in terms of the calcified nodule. So let's introduce this case. This is a 70-year-old female male and stable angina, and this is how it looks like the picture. Wow. And you see like the thrombotic-like of the picture, but patient is stable angina. And whenever you see young interventional cardiologist in this room, please remember this picture. Whenever you see this type of the picture, you may think this is thrombus, but you should have the differential diagnosis. Differential diagnosis should be the calcified nodule. And two large, almost like the radiolucent area, that's indicating something very unique. And we did the OCT, and this is after balloon, and this is a distal and large right coronary artery, not much calcium, but you start seeing the calcium in the 9 o'clock, and then this is balloon effect, and coming back, this is a calcified nodule. And it's a little bit difficult. Let's go to the next still image. So these two radiolucent segment corresponding OCT picture is really the calcified nodule. The calcified nodule is the accumulation of small calcium fragments on the top of the calcium plate. So if you zoom out OCT, you see the small calcium fragments inside of the big chunk of the nodule. This is how it looks like the calcified nodule. But many times, early beginners confuse this could be the red cell thrombus because there is a lot of attenuation. But this is also very important typical picture to define the calcified nodule. The calcified nodule always having this type of strong attenuation because inside of the calcified nodule there is a lot of fibrin, and that's causing this type of attenuation. So this, and by the way, if you have the doubt, doing the IVAS could be the best. This is a different case, but we did the same case by IVAS and OCT because this patient, by the way, a patient coming to the hospital with cardiac arrest. And then we did the angio, and then it's not very clear. And then we did the OCT for the right coronary artery for the intermediate region, and we found this. And I saw this is calcified nodule. Okay, this is stable calcified nodule, but everybody argued me, are you really sure? Are you really 100% sure this is not red thrombus? Everybody argued to me. So I opened the IVAS. Okay, let's do the IVAS. If you see the IVAS, you are 100% confident. If you are doubt, do IVAS. And the right-hand side, it's clearly calcium. So that's sometimes confusing, but whenever you see the IVAS, you can understand how to say the calcified nodule. And the bottom picture is a pathologist. The calcified nodule is small calcium fragments. Okay, let's go back to the case. So this case, we did the orbitally, and we did the balloon, and we put the stent and long stent to cover everything. This is after everything, and we are very happy of this result. And by the way, this is final OCT picture, and looks like a good stent expansion, but already you start seeing the calcified nodule is actually a little bit protruding through the stent. You see here, right? And then, by the way, this patient having the LAD lesion and staged procedure, and the patient coming back 5 weeks later to treat the LAD. But just in case, the operator did right coronary artery injection, and everybody surprised. You see almost deja vu, meaning the calcified nodule again in the same spot. And wow. And we asked the patient, are you really taking the antiplatelet therapy? And he said yes. And we really confident patient taking the DAPT, that's for sure. Okay, so, and then we did OCT again, and we are so surprised. This is how it looks like inside. This is only 5 weeks later. I show you good stent expansion, but already some protruding the calcified nodule. Now, almost everything is reprotruding to the stent. And then again, people doubt, are you really sure this is not red cell thrombus? And actually, we did IVUS, and then we confirmed this is calcified nodule. Wow. And then we debate, what should we do? And the only thing which we said may be better than before is let's put the Megatron, because radial force is better. And we treat, and then we put the Megatron. And this is how it looks like at the end. And again, we are comfortable. But we don't believe a lot, because it looks like this is coming back again. And this looks like the final. By the way, 5 weeks later, and again, patient coming back for the final stage procedure of the LAD, and I thought this is okay. But the operator was so careful, and he worried a right coronary artery, and actually he opened the OCT and checked the inside. Actually, there is a protruding, but less protruding, so we are okay. Lumen was preserved, so we thought this is okay. But this is how it looks like. And if you look into the literature, actually this type of phenomena is not super rare, already published. Many of them was case report, meaning that treating the hemodialysis patient and coming back quickly and then almost recurrent. And then pathologists also show this is reprotruding calcified nodule through the stent, because again, the calcified nodule is small fragments of the calcium, can be reprotruded. And then there is a bunch of the case report if you can look into. And there is a paper from Japan. They analyze majority all patients, and then they divide calcified nodule patient but without. And then if the patient having the calcified nodule, they have poor outcome. And then they did about 80% of the time, they did follow-up IVUS. And then they saw that reprotruding calcium inside of the stent within 1 year. So this phenomenon seems to be real. By the way, we go ahead to do more. And then I wonder, all calcium could be same or could be different? And my answer is no. So I asked my fellow to look for the as much as calcified nodule. And he checked the 7,000 OCT in the St. Francis Hospital. At the end, he found 200 calcified nodule. And we look for the 200 calcified nodule. And ultimately, we recognize there is definitely two types of the calcified nodule. Number one is so-called eruptive, meaning there is like the very irregular surface. The other one is kind of a healed calcified nodule. Its surface is smooth, but inside of the calcified nodule, there is a two type. And acute expansion is left-hand side is better because they are almost redistribution. And the right-hand side is not because stretching non-calcium nodule side. That's how it looks like. And we ask even the multivariate model using the stent expansion as an outcome. The calcium type is really effect of the stent expansion. This is acute outcome. By the way, the low tabulator, etc., may be effect, but not too much in this data set. That's acute outcome. But if you look into the long-term outcome up to 2 years, actually eruptive calcified nodule is worse compared to non-eruptive. Acute outcome is better, but long outcome bad. And why? It's similar to what I show as a case example. So this is how it looks like the recurrent data, meaning we didn't have the OCT at follow-up, but we look into the angio, and you see the radiolucent, and then we answer. If radiolucent is present, showing red on the top, that's eruptive calcified nodule, and the bottom is dark blue if that is not eruptive. So majority of the recurrent event is due to the looks like protruding the calcified nodule because we see the radiolucent at the site of the event. Okay, I think that's all. So I think today what I'd like to show is how each modality can affect of the calcium region and how you can confirm based on the imaging. And I think we are learning more as the worst scenario at the calcified nodule, and seems to be this is really like bad things. And how to do it is actually still not super clear, but at least we are understanding, looks like all calcified nodule is not just one, and different type, and then based on this, we can differentiate the outcome, and for those, I think the imaging is helpful. Thank you. Yes.
Comments, questions? By the way, there is questions from the online meeting of the event, and the question is for case number 2 in the previous presentation: why did not use intravascular lithotripsy, and what is your opinion about this mode of treating calcium?
I'm sorry, case number 2.
There was this right coronary, which was
yeah,
birthed
yeah.
with 2O.
Yeah, actually, lithotripsy didn't go.
And what is your opinion about, is it worth having this modality?
That one?
No, I mean lithotripsy is a modality to address calcium.
I think that's super good one, meaning like the rescue, right? I mean, this is a case which I saw is that like somebody already put the stent without understanding what's happening behind, and the super underexpanded, and we see the calcium behind. Even acute phase, lithotripsy can help because they can make the fracture even after stenting. So it's really the rescue. So that's number 1. But to me, like the case number 2 is super severe calcium, and I couldn't see the sickness because it was IBAS. But I guess that's very sick calcium based on the reaction of any device. Those probably difficult even without having the atherectomy. So I think the lithotripsy seems to be my feeling based on the imaging finding is something super severe could be atherectomy necessary, but moderate diffuse and some after the rotablator doing the lithotripsy seems to be the best. And then like the very moderate, and maybe we can do by balloon only, but could be better by lithotripsy. Those are the very good indications. Something like those are the range, which I think.
Thanks.
Valerie, may I just one remark? Akiko, my question is, so I'm shocked a little bit with eruptive calcific nodules. I presume that this is most rapid atherosclerosis connected to strong calcifications. This is a very active process, and probably the mechanism of calcific nodule formation is different to other form of calcification. So probably we need additional drugs for that. Might be, let's say, anti-inflammation drugs. And I personally, looking at the images, especially for in OCT, I'm pretty sure that nodule, this eruptive one, they have to be additional substances, particles, which are active, able to grow up in a such short time. And
yeah, I think I agree. I checked the calcified nodule many in the Renu's lab. I went to her office and I asked her to show me the calcified nodule in the pathology. And when you look into the calcified nodule in the pathology, there is a lot of nodule inside of the plaque, meaning that really we look for only the iceberg on the tip, on the top of the lumen. So we see some, but actually inside there is a lot of nodule. So we don't know how much behind, because of even IBAS OCT, we couldn't see everything behind. So, and also, by the way, the calcified nodule occur in the hinging portion at the most, like the mid-right coronary artery or stem. So they are hinging, and then also that's a frequent place of the calcium stent fracture. And then they are like always like having the shake, and then even you put the stent, they are more likely pulling out again. So I think not only the morphology, but also the mechanical things that's causing the whole issue.
Maybe if we go a step further, we will need another stent in
Yeah, or
such a
no-
situation
Yeah,
with
yeah,
another mesh. in
yeah.
that
Or no stent.
place.
Because it looks like even put the stent, it's coming back. So doesn't, yeah.
Should be very
And I
close.
think my belief is taking out some amount could be better, but we do orbitally or rotor, but we cannot take too much. So what is really the good thing for those is really we have to look for more.
Okay, so move further.
Thank you.
There is
Thank
a
you
question.
very much.
There is a, Valeri, there is a question. There was a question.
There is another question from the audience. Okay.
So
Thank you.
I can see
Wait,
Dr.
wait.
Mileva. Can you hear us?
Валерий,
There is a question.
дайте само да чуем колегата.
Sorry, I was asking for. We speak about the calcium nodal plaques that are actually we never do the histopathology of the intima media, and maybe myocardial MRI perfusion can give us much more information about these live plaques, because as we saw, after predilatation, after putting stent, after rupturing the calcium nodules, we have actually angered the plaque and actually start developing more instant rest stenosis or developing a new. Maybe myocardial perfusion can give us much more information about what's happening into the intima media of these calcium nodules or vascularization inside the plaques. Thank you.
That's a nice comment. Probably this is something, a new niche in interventional cardiology to develop and to discuss. Dr. Mileva, can you hear us?
Hi. Yes, hello, can you hear me?
Thanks for joining us, and please take your time for the presentation.
Thank you. I'm very happy to be able to present today, although I'm not there with you. I'm still very grateful for this opportunity, and I'm extremely happy that I can speak about CT and coronary imaging today. I have nothing to disclose, so I would like to start with something that we already know, that yes, coronary CTA has been used mainly as a non-invasive tool just to diagnose if there is non-coronary artery disease. And the trial of Scott-Hart is a very famous one. And it showed that the CT strategy added to the diagnostic strategy in patients with stable coronary artery disease led to improved clinical outcomes at the 5-year follow-up. Therefore, the coronary CTA diagnostic strategy has been included in the clinical practice guidelines. And CT has been recommended that as the gold standard for non-invasive imaging in patients with stable coronary artery disease. However, if we go back again to Scott-Hart, it's something that I really would like to stress on, that in patients that were referred for, that were in the CT group, there were no less coronary revascularization and no less invasive coronary angiographies performed. So it's important to remember that the better clinical outcomes in the CT group were not related to less revascularization. So these patients were also sent to the cath lab, also stented probably, but something led to their better clinical outcomes. So the CT actually helped for better, probably helped for better interventional procedure. So at least in Bulgaria, we hear a lot that we should perform CT in order to avoid the invasive angiography, so to exclude CAD and to avoid the referral to the cath lab. However, I really think that there should be a shift in our way of thinking, and that we should believe that coronary CT angiography is actually a complement to the invasive angiography. And there are reasons about that, okay, before with the previous CT scanners, the classical indications for a patient referred for CT were patients with strictly sinus rhythm, with really low heart rate rhythm, with really BMI under 25. Now, with the better CT scanners, with the advent of technology, we can do CT also in patients that are overweight, in patients that are with in arrhythmia, with atrial fibrillation, and even in patients that are previously stented or had surgical revascularization. So this advent of technology is leading to more and more expanding the recommendations of the CT. If before it was only a diagnostic tool to rule out CAT, now we have it also to plan the procedure for functional assessment, but also to plan the type of revascularization in high-risk patients, if we should do PCI or CABG. And so if we go to the day of the question about calcified vessels, can we really use CT in calcified vessels? Because before there was this, again, stigma that CT is contraindicated basically in patients with severe calcifications. But we should know that there, again, with the advent of technology, there are actually specific protocols for calcified vessels, both for acquisition and for visualization. And if we focus on the acquisition protocol, again, with the advent of technology, now we have the artificial intelligence so implemented in the CT softwares. So usually the artificial intelligence is increasing the tube current when it detects higher calcified plaque in the specific patients. However, okay, we have the acquisition protocol performed automatically, but then when it comes to visualization, it's completely up to the physician. And we should be aware that there are specific visualization settings for patients with higher calcifications. And we see in the study that was performed back in 2001 that the higher the window level, the less variability in the luminal diameters. If we go back to, if we see the left part of the diagram where there are the lower Hounsfield units, so lower Hounsfield units mean low intensity plaque, so non-calcified plaque. There, the window level, we can agree with the lower window level, but the higher the Hounsfield units, so the more calcified plaque, we need to increase the window level in order to assess the plaque burden and the plaque volume more accurately. And there is one very interesting study performed by the group of Aust. In this study, they compared the calcium burden in patients that had performed both CT and no-CT. So we see this is one vessel with CT and no-CT. The length of the vessel is matched, and then the calcified plaque is contoured and is quantified both in CT and no-CT. And then the plaque arc, plaque volume, plaque length was compared. And it's very interesting to see that when we assess the calcified plaque length, there is excellent correlation with a very small difference, with very good agreement between CT and no-CT. However, when we go to the calcium plaque volume, yes, we see that CT is overestimating OCT. However, there is a very good correlation once again, and we see that this overestimation by CT is actually systematic, and this systematic overestimation, if we look here, is 60%. So we can hypothesize, we can conclude that CT is overestimating calcium volume compared to OCT, but this overestimation is around 60% always. So we can still make conclusions about calcified volume in CT. Therefore, the calcium severity classification has been developed. This classification is based on CT cross-section images of calcified plaques, and we see that from grade 1 to grade 5 is it's more and more severe calcified plaque, and this classification is based on the calcium arc. So the higher the calcium circumference, the higher the grade of the calcium severity. What is more, this classification has been assessed as part of the predictors for rotablations. And we see that we assess patients with higher calcific lesions, which underwent or not rotablation, we see that there are CT parameters that are independent predictors of rotablation. Of course, one of them is the Agaston score, so higher calcium score, higher probability for rotablation. But what is interesting is that also it is the lesion length from the CT and the grade 5 calcium plaque pattern, which I showed you here. So the higher the calcium circumference, the higher probability for rotablation from CT. And if we keep on going with the CT validated and developed scores, we have the CT Rector score, which is a score validated in patients referred for CTO. All these patients had CT coronary angiography performed before the CT revascularization procedures. And we see that severe calcification is a very important parameter of every chronic total occlusion. The presence of any calcium involving more than 50% of the vessel cross-sectional area, so this means more than 180 degrees of the circumference, is part of this score. This score was compared with the JCCTO scores, and we see that the higher the score, so the higher the calcifications, the less successful crossing of the chronic total occlusions. And as I told you, when compared with the JCTO score, we see that actually the CT Rector score, the score validated and developed from CT images, performs better when compared with the JCTO score. What is more, a randomized trial was performed on patients, again, referred for revascularization of CTO. They were randomized in two groups. One group was referred for pre-procedural coronary CTA, and one was directly referred for angiography, so the angiography guided group. And what we see is that actually the one that were referred for CT has 10% more successful revascularizations than the ones that were only angiography guided. Interestingly, at follow-up, we see that the coronary CT guidance group had less major adverse cardiovascular events. And if we take a little bit more detailed look, we see that the difference comes from the peri-procedural MI that was higher in the angiography guided group. So here, if we think further, probably this can be related again with the plaque visualization from CT, which helped for the procedure. Here, I would like to show you one clinical case from our practice. It is a 62-year-old male patient that was referred to our clinic with precordial oppression. He had a history of arterial hypertension, and he was a heavy smoker. On ECG and echocardiography, there was no specific findings. However, we performed the coronary CT. And as first part of our coronary CT protocol, we have the calcium score. We see a very high calcium score of more than 2,000. And we see that it's distributed in the three vessels, but mainly in RCA and LAD. And if we go and see the cross-sectional images, we see the severely diffused calcifications along the LAD. And if we go to the MPR images, we see that the LAD is again diffusely calcified. The plaque is starting from osteoproximal segment, going to the mid segment. And importantly, if we look at the cross sections, we see that there is calcific plaque both on osteosegment of LAD, but also on the ostium of the first diagonal. So also a bifurcation stenosis, again with highly calcifications. And if we remember the calcium severity classifications from a few slides back, we see that here we have full circumference calcifications. That what parts of the vessel we have 60 degrees of calcification. So predictor of rotablation, predictor of worse procedural outcomes. We can see also the circumflex in the right coronary artery, both calcifically diseased, but in my opinion, the LAD is the one that is most severe. So the patient was referred for invasive coronary angiography and PCI. Unfortunately, here we do not have the movies, but you will have to trust me that the PCI of the LAD and the diagonal was performed with predilatation in both vessels and stenting in both the main branch and side branch with pot and kissing balloon. Anyway, we caught the patient 1 month later after this procedure to assess the result, but also to assess the right and the circumflex artery. And so here is the final result of the previous PCI that I could not show you. We see with, for me, very good result in LAD and the diagonal branch. If we take a look again, on the right coronary artery, we can see that there is a significant stenosis of the PD branch. We can see also severe calcifications from here. You can see the critical stenosis of PD and balloon dilation with drug-eluting balloon was performed on the PD. And this is the final result. So, in conclusion, coronary CT should not be performed to avoid angiography, but it is actually a complement to the invasive assessment. It provides information that is beneficial to plan the procedure and to choose adequate devices prior PCI. Something important, potential usefulness of coronary CTI to guide the interventional procedure is being explored currently. Thank you for your attention.
I would like to thank to Dr. Mileva, who is ex-fellow of AUST, and Dr. Barbato. So questions, comments about the CT? Dr.
I have a
Stoyan?
comment about the CT. I really believe that the CT, it's going to be the gatekeeper to the cath lab in the near future. And if we decrease our threshold to do CT, we can have a patient that don't need invasive procedure, and the patient that need invasive procedure, we can build up our strategy, our plan to do PCI, and we can achieve better outcomes. That's why I really believe that we should have more and more CT scans in the future.
Dr. Barbato?
Well, what I believe, well, first of all, congratulations to Nia. It was really an excellent presentation. By the way, I took a photo of you that I sent over to AUST just to show how good you were doing in the meantime, just inside the conversation. What I really think CT can make a difference is in reducing bailout plaque modification strategies. You know, by gathering experience, the more kind of procedures you do, like this one, the less you start doing this procedure with balloon first. And the experienced operator knows exactly, it's difficult to explain with solid data, but the experienced operator knows exactly whether a lesion should be attempted first with a balloon rather than move directly to rotational atherectomy or IVL as first intention. CT really closes the gap of experience. You know, if patients are preceded by CT before getting to the table, no matter how much experience you have, you can already anticipate the amount of difficulties that you're going to face when treating these patients. And perhaps you can open up your intravascular imaging catheter and do that instead of treating the patient just based on angio. That is where CT can be a game changer, really in the planning of the procedure and reducing complication, as he was saying.
Yes, now there is expert consensus about the PCI planning based on the CT at the moment. Unfortunately, there are not so many centers where this could be applied because it needs a good CT specialist, and this is not always the radiologist, but actually it is my personal convinced that it should be cardiologist. Without cardiologist in the CT lab, it will be difficult to go further. And now we have a little bit, how to say, competition with the radiologists in that field. I think it is everywhere in the world at the moment,
Yeah.
but it should be resolved. Okay, another questions or comments? If not, I would like to thank for all panelists for comments and questions, and we will move further. Thank you to Dr. Mileva for the excellent presentation.